All right. Thank you. Thank you so much, Dr. Nahum. It's very, very powerful and, personal experience on this big issue we are facing. So the next session, we move to Professor Jonas Geda, and he's going to talk about user-friendly and evidence-based psychosocial intervention. And I'm sure most of you know, but just for sake of introduction, Professor Jonas, he got his medical degree from Addis Ababa University, and then he completed his residency in psychiatry, followed by a fellowship in behavioral neurology at Mayo Clinic in Minnesota. So Mayo Clinic is one of the leading medical institutions in the US. Following his training, he was a full faculty and promoted to professor of neurology and psychiatry at Mayo Clinic. And he has been there in Minnesota for about 25 years. And I think very recently a few years back, he moved to leadership position to Barrow Neurological Institute in Arizona as a professor and director of global neuroscience and mental health program. He is currently he has active clinical practice in the division of Alzheimer's disease and memory disorder program in the Department of Neurology and Behavior at Barrow Neurological Institute. And he's very active in teaching and directing the global behavioral neurology program, fellowship program, and he's really very, very active in research and has over 160 peer-reviewed publication in mostly in high impact factor journals, including JAMA Neurology, JAMA Psychiatry, American Journal of Psychiatry and Neurology. And he, most importantly, has dedicated most of his time to train Ethiopian nationals and here in the US and also traveling, and through the P2P program he's actively involved with to share his experience and train younger generation. So without further ado, Professor Jonas, thank you for joining us.
Thank you, Professor Tesfaye. So good evening, good afternoon in Ethiopia. So let me share my slide. Okay, see here. So you can see my slides, correct?
Yes, perfectly.
Very good. Okay, so I will be talking about traumatic stress and armed conflict. So what is to be done, CAFER, from a mental health perspective? As Professor Tesfaye said, I'm at Barrow Neurological Institute now. I'm also a research professor at Center for Bioelectronics and Biosensors at Arizona State University. All right. So what I will do is I will talk about stress. And already we had really a great talk on approach from the Harvard group. Therefore, we don't need to go into trauma. But we will, after I talk about stress model, then we will talk about evidence-based user-friendly approach. And I will share with you some of the work that is done based on that model among South Sudanese refugees and among refugees and trauma survivors in Syria. So we all know emotion, thoughts, and behavior are interrelated. So there is emotions lead to thoughts, thoughts to behavior, behavior to emotion. They are very much interrelated. So let us use a very simplistic model. So the ABC model. So this is a very good take home. So there is an adverse event. So the armed conflict in Ethiopia that started on November 4 of 2020 is really the armed conflict. So the war was in the region called Tigray, for those of you who are not from Ethiopia, from November 2020 up to June 28, 2021, the war was in one region. And then after June 2021, it involved two neighboring regions called the Afar and Amhara regions. So that is the adverse event part. So the consequences, emotional behavior, those things we call C, emotional consequence. And then between an adverse event and trauma and emotional consequence, there is always one's implicit or explicit evaluation of an adverse event. So regarding this war and trauma, a person, an individual has his own, her own analysis about the situation. So that's the B part, the belief of the individual. So this is, okay. So the next question is, does A lead to C? Is there anything else between A and C? Let us suppose that 100 persons are exposed to horrific traumatic stress. Example, rape, death threat, witnessing horrific death, that will be adverse event. The question is, do all the 100 persons develop excessive negative emotion or post-traumatic stress disorder? As the speaker said earlier, out of 100 people who experienced severe trauma, after 6 months, about 7% will develop PTSD, not everybody. So what are the factors that make a person vulnerable to PTSD? So out of 100 people, some will experience transient angers and take action. Example, get organized to defend their village. So during the war, we have heard lots of stories. So some people were helpless and they were bound at home, and they are not able to function. On the other hand, some of those who are exposed to the trauma, they became determined to defend their village, their neighborhood to the last. And this gives them a sense of purpose. And it prevented the helplessness sensation. Some may experience overwhelming anger that prevents them from taking action. They get immobilized by excessive and incapacitating anger. Some may feel helpless and hopeless, thereby developing PTSD and comorbid mood disorders. So why is it all 100 did not have the same emotional consequence? There is a B between A and C. So a person's belief or world outlook, there is a cognitive triad. So I, others, and the world, the three frames of reference. So a person who has extremely rigid rule about oneself, extremely rigid rule about oneself. So let me see, somebody has raised his hand, Dr. Indalo Gizacho. I will let Dr. Woodina communicate through chat room. So B, one's implicit or explicit evaluation of an adverse event. The B has three components. Number one, I, for example, extremely rigid rule about oneself. I must be loved by others. Others must not be unfair to me. This is another extremely rigid rule for other persons. So if I have a very strong, strict rule for others, by saying that others should never be unfair to me. That's one extremely rigid rule. The third one is about the world. We may have extremely rigid rules. The civilized world must be fair and balanced. Democratic countries should not be creating and spreading fake news. I remember the extreme anger in Ethiopia and in diaspora when the famous CNN, Central News Network, transmitted news by saying we are transmitting this news from outside Addis Ababa. And the rebels are about to capture Addis Ababa. This was in November. And Addis Ababa is about to fall. Then it turned out the video was not even from around Addis Ababa. And yet CNN would not retract that news. There was an extreme disappointment. And most people, I asked them, why are you so upset? Because they said, from a democratic, from a free press, we do not expect this. So that's really, when we have extremely rigid rule for the world, then we are bound to have these types of emotional reactions. So three cognitive triads about oneself, extremely rigid rule about oneself, about others, and the world. So what determines a person's belief? Of course, the phase factor, the person's phase, the person's conscious cultivation of world outlook, past emotional, physical trauma, and of course, biological, genetics, all of those things are factors. And then, of course, growth and development. Usually, implicit bias, automatic implicit bias are usually rooted in childhood. And then, of course, role models, for example, in the northern part of it, of course, in Ethiopia in general, heroism at the battlefront is valued. If a general loses war and commits suicide in the Ethiopian context, that is considered, that is a role model. So we all know about Emperor Theodorus. So he is, in every school child knows about his heroism. And instead of surrendering to the conquering British forces, he committed suicide. And these types of stories embedded in our culture are part of our belief system. That's how we form our belief system. So now I want to take you to this intervention called ACT, Acceptance and Commitment Therapy. Why did we select ACT? It was, of course, the study, the work done in South Sudan was used based on ACT intervention. WHO used it. And I was exposed to it in 2011 at Mayo Clinic. There was a speaker, invited Professor Stephen Hayes to give a talk. And he said, the existing cognitive behavioral therapy is very good, but emotions are not given that much weight. He said, additionally, he said, the therapy system is highly regulated by professional societies. So he wanted to develop a model that can be disseminated, that anyone can be trained in ACT intervention. It's not limited to psychiatrists, psychologists, social workers. Any one of you in this audience can get ACT training. So that really caught my attention. Okay, perhaps this is the type of thing we need in Ethiopia, because we have so much need, 120 million population. We probably have 50 or 60 psychiatrists or 14, 15 psychologists. So that's what caught my attention. So what is ACT? So I will briefly introduce you to the concept of ACT. So it's one of the thing about ACT is that it has only 6 domains, 6 processes. When Professor Stephen Hayes sees a patient, he will give them value living questionnaire. He will be asking them, what do you live for? And then is there lack of values? Is there lack of clarity? And then, is there dominance of past stories? So we will come to this, but these are the 6 components. So he also noted here, and these others did in their works, they noted that human beings in general, that the normal state of the human mind should be healthy, content, and happy. Psychological pain is therefore abnormal and needs to be fixed or deleted. Whereas the ACT approach on suffering is that the normal psychological process of humans could often be destructive and can create psychological suffering. Suffering is more of being stuck, not necessarily sick. So the psychological flexibility model links psychopathology, psychological health, psychological intervention. And we will come to this model. Okay. So, let's start with this. First component is value clarification, or purpose, and how we want to live our lives. What type of person do you want to be? It's not necessarily where you are now, but what type of person do you want to be? What type of things do you value? Do you value hard work, commitment, compassion, respect, etc.? So there is a valued living. Do you value taking care of your physical self-health? So we'll look at some of the questionnaire later on. And then if you do, then how about, do you practice what you preach? Committed action. So are you moving in the direction of the type of person you want to be? Or are you moving away from the type of person you want to be? And then there is this self as context. Usually people get fused with their own story. I am, quote unquote, lazy. I am this, I am that. These types of getting fused with one's own story could be handicapping, could become a self-fulfilling prophecy. And instead of saying, I am a person who could be procrastinating sometimes, meeting deadlines at other times. So rather than focusing on specific behaviors, people tend to get fused with their own story, and that becomes self-sabotaging. And then one thing that Professor Hayes and others developed a new concept, cognitive diffusion. So for example, a college student in some of their study, all of a sudden says, well, this is a difficult course. I'm going to fail this course. This is fusion. The student gets fused with this type of attitude to the course. So the problem with cognitive fusion is that it hampers behavior. It sabotages actions that can take the person in the direction of passing the exam. So if the student gets fused, day number 1 by saying, well, I will fail this course, then instead of going to library, the student is probably more likely to go to a bar and drink alcohol. So instead of cognitive fusion, cognitive diffusion. So they came up with a very simple intervention. What they did is they would rewrite it as saying, I am having the thought of, quote, I'm going to fail this course, unquote. That very simple sentence, I'm having the thought of, creates a distance between the self-sabotaging view and the individual. In fact, this diffusion, they call it. So diffusion is the opposite of fusion in their technical term. In fact, this was used in a famous trial in state of Washington, where in the West Coast, I think the neighboring state of Dr. Woodiner, and in the place where Dr. Daniel lives, there was a study on tobacco cessation. They just used cognitive diffusion, one single strategy. And instead of saying, okay, I'm craving for tobacco, I need to go for it, they will be saying, I am having the thought of craving for tobacco. That simple delay, that simple detachment, that simple distance was able to predict staying in remission or staying out of tobacco or cigarette consumption. The other key concept that they have identified, extremely important, is once a person identifies what is valuable, for example, let's say members of Alliance for Research, Innovation, and Education, they value obviously research, they value education. So a member of that group would say, okay, I value research, I'm going to study the mental health problems in northern Ethiopia, and I want to come up with some concrete plan. So this is a value direction. And then at the same time, the person has to make room for uncomfortable emotions. They should be willing to make room for uncomfortable emotions, because there could be bureaucratic red tape in the US, in Ethiopia, to get to the point you want to be. There could be 100 people who want to help you achieve your great goal. There will be 200 people who will try to delay you and frustrate you or sabotage your great value or direction. So that's where they introduce the term of willingness. Are you willing to make room for uncomfortable emotion in the service of moving in the direction of your valued life? So they call it willingness or acceptance. So it has to be linked. Willingness has to be linked with valued living. In the service of valued living, are you willing to make room for uncomfortable emotions? I always hear in our COVID-19 Advisory Council, in various situations, we hear frustrations, in both directions. From home, I hear frustrations about, diaspora, trying to do things at fast pace without following the due process of completing paperwork at the airports, etc. And then on the US side, I hear, here we are trying to help our country, but the bureaucracy is delaying it. We cannot even get things out of the airport to the community. So there are lots of things. So this is frustration, anger. So we have the person's goal is to help our community at grassroots level. In the process, the person may need to be willing to make room for uncomfortable emotions. So that's, and then the other one is, as Dr. Sadi and Dr. Leah earlier mentioned, we tend to spend a lot of time about worrying about the future, what is coming in the future, what will happen to me, to my family, to my country, to my community, to my region, to my, maybe in the Ethiopian case nowadays, to my ethnicity. People seem to be thinking along that line. So, and then other one is spending too much time in the past, loss, ruminating about loss, about hurt. So and so did this to me. And then spending less time in the present. So cultivating contact with the present moment. So really, we humans have tremendous, Joseph Ledoux, who has done tremendous work on fear behavior, fear conditioning, and anxiety. He says, we humans are endowed with the ability to plan for the future, with the ability to anticipate the future, with the ability to think of the future, and that itself seems to bring about makes us vulnerable to anxiety as well. So I think these are these are the 6 models. In short: value clarification, willingness, making room for uncomfortable emotion in the service of valid living, committed action, and fusion. And then the opposite is diffusion. And instead of being, self as content, instead of self as content, instead of getting fused with self stories, self as context. I am, above. So a person is above the sum of small events. So these are the 6 components. So we can kind of divide the 6 components into 2 major categories. So the value clarification, committee action, and attention to present could be behavioral actions, and this one's more of mindfulness and acceptance. We can also divide them into 3 categories. So one of them is being open to one's experience. Instead of hiding, running away, to be open, and then centered, present moment, and then engaged. So value clarification, committed action. So I already explained this. We don't need to go into that. So how do we measure this? So really for value, we have value clarification. So we will look at this questionnaire. For committed action, there is a bull's eye exercise that we are going to look at. And then for cognitive fusion, there is a very simple 5 questions. And then about how much time do you spend in the present moment, in the future, in the past. So let me see. For example, the cognitive fusion questionnaire, it asks never true, seldom true, always true. I get so caught up in my thoughts that I am unable to do the things that I most want to do. For example, a student wants to do well on an exam, and therefore the student knows that he or she has to study and has to go to library, purchase the right material, sit down and work. And instead, the student may get caught up in the hurt and anger for rejection the student faced when approaching a girlfriend or boyfriend, whatever direction. So this is what is called cognitive fusion questionnaire. So on the other hand, does the person make room for uncomfortable emotion and pursue the valued living? Okay, we have attachment to a conceptualized self versus ongoing awareness and perspective taking. So this is what I told you. Some people, they classify themselves, I am lazy, I am stupid, I am this, I am that. They get so attached to this conceptualized self instead of being aware. So I am having this behavior, I have done this behavior, but I am the person who will engage in something positive, something negative, something neutral. So that we know that is the case. So so conceptualize self as context. Fusion with concept leads to interference with psychological flexibility. Okay. Let's not get too much into this. So I have explained these concepts. So engaged response style. So this is both valued living and committed action. So values are verbally constructed and undergo ongoing review, allows focus on generating psychological purpose and meaning. So the one thing I like about ACT intervention really is you don't see too much of this psychological terms, and these are value clarification, committed action. These are anybody can relate to these constructs and concepts. So let's say a person called Bob identifies important values, connecting with others. Bob suffers from social anxiety, does not get out of the house. So through this ACT intervention, he values connection, then he's learning to be authentic and genuine. Usually in social anxiety, they have fear of evaluation anxieties. They have fear of how others view them, how others think about them. So that's one of the things addressed using ACT. So if taking your life in the direction of these values means you need to make room for feelings of anxiety, are you willing to do that? So this is a question that the ACT interventionist asks Bob. So instead of committed action, there could be inaction, a tendency to feel overwhelmed by a task instead of starting, in a small piece, So I think one of the motto of the Dr. Tesfaye has shared with me the motto of the Alliance for Research and Innovation and Education is, we think big, but act small. We start in a small place, in one specific place. You start with one clinic, with one university, and then slowly you build your experience on that and you move. That is basically action, committed action. But from day number one, if you want to work with Ministry of Health, with Tukur Ambassa, with Bahir Dar, with Dila, with Jijiga University, so that's really overly ambitious, overwhelming, and probably you won't go anywhere. So when you don't make any progress, then it reinforces further inaction. So that's what's meant by inaction. Another factor is impulsivity versus valued, intentional move. So okay. So committed action, one of the things is, so you have action, number one, and also action tendency, or the step you are going to take toward the specific action. So ACT really does not try to get rid of bad feelings or get over all trauma. It's about creating valued living. So the person will define what the person wants to live for. And then the person has to be willing to make room for uncomfortable emotions and do specific actions. Bob still experiences anxiety and still has negative thoughts, however, is not controlled by them. Anxiety is diminished and does not distract, and willingness of feelings give control back to him. Ironically, he has more control by practicing willingness than by experiential avoidance. So I want to talk to you a little bit about the application of this ACT intervention among refugees. But before I go into that, Dr. Woodin, I don't know, how do you want to proceed? Shall we have the discussion after this, or you want to give some chance for people to ask a few questions?
Maybe you can finish your part.
Okay, good. We'll do that.
Yeah.
Okay. So Dr. Russ Harris, he is one of the well-known ACT experts. Actually, Dr. Harris, he's a movie star, or he was an artist, actor of some sort in UK, United Kingdom. Then he pursued medicine. He became a general practitioner, GP. This is public knowledge, by the way. He says it publicly, so that's why I'm sharing. And then his son developed autism. So he wanted help for his son. So it turned out there is an expert in Australia, so he went to Australia. So this expert in Australia on autism and spectrum uses ACT intervention. So specifically, there is something called relational frame theory. And then his son improved. Actually, his son is now verbal. He is an adult. He has pursued college education. So Dr. Harris, a very brilliant man, so he studied this thing, and he got more training in ACT. And now Dr. Harris is giving more training. In fact, it was his manual that was used by WHO in South Sudanese refugees. And actually, there is a 6 weeks training in ACT intervention. So in Ethiopia, Professor Mesfin Araya, Dr. Tafarra Bayero, so my colleague, we were together at General Wingate Secondary School in the old days, and Dr. Aida Tafarra, the young psychiatrist, and I think a couple of other people did get this training, the online trainings, that the 6 weeks trainings that Dr. Russ Harris gives. So his model was used in refugee camps. These are Sudanese refugees, South Sudanese refugees in Uganda. So this finding was published in Lancet Global Health in 2020. So the most women had experienced repeated gender-based violence, as well as horrors of warfare and ongoing stress of living in a camp of 250,000 refugees. So now war trauma is close to all of us. So because of the there was a war going on in northern Ethiopia in a very large landmass, a landmass as big as Germany or as many European countries together. So it's a large, involving millions of people, 7 million, 8 million, or 15 million people. So we have also heard of horrors of gender-based violence in Ethiopia. So we can now, this is no more, the story about Southern Sudanese refugees is no more a distant story. It is our own story as well. And so this intervention involves a target group. So there was 10 hours of ACT. It was delivered in a group program. It was run by lay facilitators, not by psychiatrists, psychologists, lay persons. And it resulted in significant reduction in both PTSD symptoms and depression. Even though, as I told you, the primary goal of ACT is not to delete symptoms. It is rather to cultivate valued living, committed action, willingness in the service of valued living. But as the person pursues those things, secondarily, symptoms go down. In fact, ACT has been used even in psychotic patients. A person called Patricia Bach, B-A-C-H, at the University of Illinois in Chicago. She used ACT intervention among psychotic schizophrenic patients. And the study showed that it prevented readmission rate significantly. However, the awareness of the psychotic patients about hallucinations and delusions increased. So they reported more hallucination and delusions. That's because they were more in tune with their thoughts. And instead of experiential avoidance, they were more in tune with their emotions and thoughts and behavior. So it has been used. So the primary goal is value clarification, committed action, and willingness, cultivating those skills. Secondarily, symptoms get reduced. So stage one, so 1 to 2 sessions. They take history, they talk about, informed consent. Are you willing to participate in this? They establish goals. And then there is psychoeducation on trauma in a very simple, concrete terms. And there is something called dropping anchor exercise. So basically, there is this audio that the group listens. I will put it up later on. We will have an experience on the dropping anchor. Then living in the present, they start with that exercise. Then I told you they exercise about, instead of fusion, diffusion, and then acceptance, self-compassion, clarifying values, committed action, breaking destructive patterns, then healing the past. So there are these different grieving, forgiving, exposure to traumatic memories, building the future, long-term goals, ending therapy. So these are the things. So basically, this is on ACT. So I think earlier I told you in the ABC model, A is adverse event, C is emotional consequence, and B is a person's belief. So I think in the current day Ethiopia, some of the work in social psychology, Dr. Aronson in Stanford and at University of Michigan, the very famous social psychologist, originally from Jamaica. He and many others have done a lot of work on group behavior. So I just want to propose a theoretical model that, one of the problems in Ethiopia could be related to this model. So I told you about ABC model. B is a person's implicit or explicit interpretation of adverse event, and then one possible contributing factor to conflicts in Ethiopia since 1992, between 92 and now, there have been really unprecedented, in the history of Ethiopia, unprecedented group conflicts, ethnic conflicts. And I grew up in Sidamo, Irgachefe, Dilla, Hagaramaria. I have seen small skirmishes. My father was a governor of Hagaramaria. He used to go, he would take just one soldier, he will drive into the rural community, he will hold Auchachin for a month, they resolve, he comes back. Now you need 2 brigades to go to this community, so it's really unprecedented. So why is that? One of the social psychology model I would like to propose is overemphasis on differences and devaluing group cohesion. So in social psychology, you have to balance group cohesiveness and diversity. Although both group cohesiveness and diversity are integral components of a productive group, too much of either will interfere with optimal performance. So most of these studies are done in different group settings, but I think this could be a relevant theoretical model. A group should have enough in common to be compelled to work together and complete a task, but should also be diverse enough in that they bring new perspective and innovation to the project. So for example, if you have a team of researchers, one could be a neuroscientist, one could be genetics expert, one could be epidemiologist. So these are diverse experts, and they come together, and then the cohesion is the common research agenda. So that's a good example of balancing group cohesiveness and diversity. So this is, if you apply it, this has also been studied done in ethnographic studies as well. And so I think part of the issue is that there is overemphasis on the diversity aspect and people over-identifying with their ethnic group, excessively identifying and then neglecting the cohesiveness of the whole the whole country, a sense of identity as a country. That cohesiveness gets diminished, and primarily focusing on excessive focus on diversity. And this takes us to what Irving Janis, Janis, he was actually a research scientist, research psychologist, neuroscientist at Stanford. But he was very curious. He said, why is that sometimes destructive decisions are made? Why did the US government, a superpower, lost a battle at the Bay of Pigs to Cubans in 1960 or something? Why did the US lose the war in Vietnam? Is there any psychological group behavior model we can look into other than political and other economic, etc. issues, military issues? So he studied that. What he found out is that during the Bay of Pigs, there was advisory group that was making a decision, which was led by President John Kennedy. So John F. Kennedy, of course, is a charismatic leader, very persuasive speaker. And the members of his advisors were really Rhodes scholars, Harvard scholars, well-educated people, very independent-minded people. Whereas in that group setting, everybody sensed what Kennedy wanted. And then conformist, conscious or unconsciously, people started to conform to what Kennedy wanted to do. Therefore, everybody started to support, say yes, when a dangerous decision was being made. Sure enough, they went and they lost at the Battle of Pigs to a new Cuban government. Another one was the same advisors. They were discussing about Vietnam. So they slowly started to escalate the involvement of the United States in Vietnam. And this eventually led to a destructive outcome. Whereas, on the other hand, the Cuban Missile Crisis was successful. Why? Because the advisory group intentionally decided to identify a devil's advocate. I think it was John Kennedy's brother, Robert Kennedy. Of course, he's your brother, so he will not kill you. So Robert Kennedy, I think, was challenging every major idea that was coming to the table. And as you know, the Cuban Missile Crisis was very successful, the way it was handled by the US government. So groupthink that's where people in groupthink, it's a highly cohesive group. They are thinking as one person, usually in the presence of a charismatic leader, a directive leader, a leader who is not shy to dominate, to come up with great ideas, and yet does not have a challenging voice in the group. So just a second, I think there is some noise. Okay, so this is what Irving Janis called groupthink. And so it's how do we deal with groupthink? So the other problem with groupthink, people, excessive cohesiveness, the group member tends to overestimate they have this illusion of not being vulnerable. So I think in the armed conflict in Ethiopia, most likely on November 4, the people who started the war, the groups that started the war, they were very sure of winning. Otherwise, I don't think they would have made this blitzkrieg attack, they call it preemptive strike against the Northern Command, because they felt that they are being encircled by Ethiopian government, Eritrea, and that's how they perceived it. Therefore, before they attack us, let's attack them. So they had this sense of invulnerability. So they believe in groups' inherent morality. We have the truth in our hand. We have the upper hand. We are advocating for this and that cause, whereas the Ethiopian and Eritreans are advocating for that or those, for oppression, etc. So this is overestimation of the group. The other problem with group things, there is a tendency to be closed-minded. There is collective rationalization. The group starts to think the same way. We started the war because we were threatened, encircled, the Amhara from the west, the Eritrea from the north, this one from the east. They were coming. So they reached out to as many people as possible to help them fight back. And then there is also a stereotype about out-groups. So in-group, out-group bias, so the others versus us. So this is the type 2. And then the third one is pressure towards uniformity. So people try to engage in self-censorship to fit into the group. They stop voicing opposition. I am sure November 4, if there was someone who was objecting the blitzkrieg, the surprise attack within that group, I don't think there was one. If there was one, probably the person could be killed by now. So this illusion of unanimity, direct pressure, putting pressure on dissenting voice within the group. And then, of course, self-appointed mind guards. There will be a few people who say, okay, you are not following the vision of the great leader or the beloved leader, etc. These are the type of model that has been used. So in China, in various situations, this has been observed. So I think this group thing could be a relevant issue. So how do we prevent groupthink? So leaders should encourage open climate of giving and accepting criticism. Leaders should be impartial and refrain from stating personal preferences, particularly prematurely. Establish multiple groups with different leaders to work the question in parallel. So each member should privately discuss current issues and options with trusted associates. From time to time, bring in outside experts to challenge the views of the core members. There should be one or more devil's advocates. I think number 7 would be extremely important. Advocates during every group meeting. In conflict situation, extra time should be devoted to interpreting warning signals from rivals and to constructing alternative scenarios of their intentions. Reconsider the decision in second chance meetings before going public. So there are ways of preventing groupthink, at least based on studies done, Rose and others have published on this. So I would like to give acknowledgement. So I had a lot of help. Well, always in research, as you all know, you have to have a very strong team. And when the team member is very productive, does not even want to be on slide 1, just at the last, a small acknowledgement, that's how you become more productive. So thank you very much. That's what I have, and then we can proceed to the discussion.
Thank you so much. This is really wonderful presentation, especially the idea of how we get out of the group thinking. All these things are really important. And I think we'll open for discussion for a few minutes and then continue with Dr. Aida. So anyone, you can unmute yourself, and you can talk in Amharic or in English. So I think most of us, we can understand each other now.
Okay. I will invite someone, but first, thank you, Dr. Jonas. For those of you who don't know him, he's been trying to do a lot of work back home in Ethiopia, and we've been discussing a lot of things. He has a lot of plans. I just pasted my email on the chat, so we need a lot of information from the local people, what the problems are. Dr. Jonas, Dr. Tasfai, Dr. Udana, and I, and others in the group are thinking about writing papers, really bringing the problems out. So we will do that. Please just keep contacting us.